Okay, no problem.
All right. So, good afternoon and a very welcome to this exclusive academic exchange. So today we have the distinct privilege of hosting a focused dialogue between two internationally renowned leaders in nephrology, so centered on a critical topic, exploring the application of hemoadsorption in kidney transplant. So joining us are Professor Dr. Hemoadsorption Yavuz from Turkey and also Dr. Isa Kawalit from Jordan. And we also want to extend a special welcome to our highly trusted industry partner and Jeffron Sales Director. So this session is designed as an in-depth conversation to share clinical experiences, discuss challenges, and also advance our understanding together. So
Thank you.
This session will be structured into three segments. First, Professor Dr. Yavuz will share clinical cases from Turkey. Then Dr. Kawalit will present a case from Jordan. So finally, we will move into a host expert dialogue where both speakers will discuss key topics and exchange insights. So to begin with, I'm pleased to invite Professor
great.
Dr. Hemoadsorption Yavuz. So Professor Dr. Yavuz is a specialized nephrologist with over 20 years of experience. So she is currently lecturing and practicing at Medical Park Antalya Hospital. Her work focuses on kidney transplantation, dialysis, and chronic kidney disease. And she has co-authored many influential studies in the field globally. So Professor Dr. Yavuz, the floor is all yours and you may share your screen.
Okay, nice to meet you here. I am working in this center in Antalya since 2011.
Okay, yeah.
Our center founded in 2008. We have got more than 7,000 patients here in this center. This is our case. She's 57 years old female, and she has got first kidney transplantation from her uncle in 2016. Then she lost her kidney 1 or 2 weeks, as she remembered. Then she was on dialysis for 9 years, and she had get kidney transplantation in February this year in our center from cadaveric donor. During this kidney transplantation, she has had also right native nephrectomy. Her primary kidney disease was polycystic kidney disease. Other native kidney nephrectomized 9 years ago during previous transplantation, and she had also graft nephrectomy in the first kidney transplantation. During the postoperative follow-up, we have no problem. Urine output is around 800, then decreased a little bit. Then we started ATG thymoglobulin to our patient accordingly. Then prophylaxis for antibiotic, we usually began ceftriaxone all our patients, and she has no problem after follow-up. And transplanted kidney Doppler ultrasonography was good. There's no problem again. But a little bit CRP infectious level get high. So I usually speak with surgeons and infectious disease doctor. She has had a kidney from cadaveric donor. Accordingly, they want to change antibiotics. Then we continued together with ATG to plasmapheresis to her. And she has had urine output nearly 3 liters in a day, then 4 liters. And during, again, as you see here, 5 liters urine, and creatinine level begin to decrease from 10 to 8, 7, 6, 5, 4, and 3.7. She discharged from hospital. I usually follow those patients by myself in my nephrology clinic, and in the next polyclinic day of her creatinine increased to 5. And there's a urine decrease. We didn't get urinary catheter out because she was on dialysis for 9 years, and her urinary bladder may be small. Then because of this, we just ordered to her again methylprednisolone pulse treatment together with ATG and plasmapheresis. Then plasmapheresis and ATG continued. But her urine was decreased, and she was a little bit put on weight, nearly 9 kilo more. And then we did hemodialysis together with ultrafiltration of 5 liters. Kidney transplant Doppler, there is no problem, but there's a small in length, 15 centimeters, in width 3 centimeters collection in her wounded area. Then we continued together with ATG and plasmapheresis treatments. Her hemoglobin level is a little bit low, but there was no bleeding. Then we ordered also 1 unit of erythrocyte suspension to her, and accordingly, platelet numbers is 100,000. We started to think about biopsy, kidney biopsy to transplant kidney. And also surgeons started to think about second loop operation to take her another operation or not, and during operation maybe biopsy. Because of low urine output and her conditions, then I ordered, at those days, Jaffron was here. Nicolas was here. He's in France now. I was discussing with him about immunoabsorption of Jaffron filter. Then I want to make her another dialysis together with this immunoabsorption filter. Her urine 700, 900, then 500 urine output. 2 days of Jaffron we ordered to her together with dialysis. Jaffron filter and dialysis filter were ordered at the same time, and then her urine output began to increase. And we have also DTP scintigraphy to her. There's a rejection, there's no urinoma or another problem, and risk index of transplant kidney ultrasonography is 1. And then we continue together with dialysis only, then continue to treatment with ATG together with plasmapheresis. Then her urine began to increase nearly 300, 3,000, 4,000, 5,000, and now in her last condition, nearly February, 12th of February, we did operation. Nearly 8 months passed, and after operation, she had a rejection, and we did all the treatments. And she had a polyneuropathy problem, pancytopenia, infectious problems, a lot of problems also together with deep vein thrombosis. And we changed her tacrolimus. We usually give our patients tacrolimus, mycophenolate mofetil, and steroid for treatment. We changed tacrolimus to cyclosporin, and she continued to physiotherapy. Now she's good in condition. She can walk by herself. And her kidney is good also in condition. And as we can see here, rejection, unfortunately we didn't do biopsy, We don't know what's the problem, exact problem. There's a T-cell mediated rejection and antibody mediated rejection or combined rejection in kidney, in transplanted kidney, and we gave our treatments accordingly. So I thought we did before immunoabsorption, we did 5 times plasmapheresis and no answer according to plasmapheresis or other thymoglobulin treatment. So I thought that I just checked literature and immunoabsorption column can effectively remove C3, C4, IgG, IgA, IgM, and other inflammatory mediators and harmful substances in blood in zoo study shared in 2016. And maybe because of this, and also HA2 280 and DNA 280 immunoabsorption comparison in lupus patients. This is another study from SU. ANA and double-stranded DNA levels before after very good decrease in their levels in usage of immunoabsorption to them. And also I see that in another study, France study, HLA antigen desensitization immunoabsorption is effectively reduce or eliminate donor-specific antibodies in 71% of patients. So also to another study, this is double membrane filtration immunoabsorption, double membrane plasmapheresis, the double filtration plasmapheresis together with immunoabsorption also effectively remove C1q de novo DSA positive treatment refractory to antibody mediated rejection. All of them show us that also in incompatible kidney transplantation, usage of immunoabsorption is also effective. I see that maybe combination of immunoabsorption to kidney transplant patients together with rejection is can be a good choice, but I couldn't find so much data in literature. Maybe in future time it can be or studies can be planned or done to use immunoabsorption together before kidney transplantation to decrease PRA levels of patients or after kidney transplantation and together with acute humoral rejection patients. It can be very useful for kidney transplantation patients. So thank you for listening to me.
Thank you, Dr. Nice presentation. But I have questions, if you don't mind. First, I don't know what was the mismatch and what was your initial protocol? Because I heard that you gave the ATG after 1 day or 2 days of the transplant. And what was the reason you didn't do the kidney biopsy to define her underlying disease?
Her 4/6 HLA mismatch, cadaveric kidney transplantation, donor was cadaveric, and our protocol, usual protocol in our center is usage of anti-thymocyte globulin together for second transplantation or other for example, lupus patients, we order plasmapheresis. Together with plasmapheresis, we started, and her urine output was good, her creatinine decreased. So we didn't need to do any other biopsy or other things. But after we hospitalized her for rejection, we planned to do biopsy. But her clinical condition and urine output was less. Her clinical condition was not so good, and surgeons thought to take her to second look operation and do this biopsy during this operation. or to take a kidney out, for example. They just thought this, and I couldn't do biopsy. Just wait for their response. And also we did her hemodialysis because she has got an overvolemia, and we took some volume out. And after we thought to continue to dialysis, but at those days Nicholas was from. So I just thought to add immunoabsorption to her. After immunoabsorption for 2 days and together with dialysis, her urine gets out much more than usual. Everything getting better than we didn't do biopsy just because of this.
I agree with you, Doctora, and I am very reluctant to do a kidney biopsy. Very reluctant to do a kidney biopsy post-kidney transplant. Yani, risks are usually there. But thank you for the presentation, Doctora. And my presentation is easier than yours. So I don't know if you have my slides ready.
So thank you, Professor Dr. Yams, for that insightful presentation. So now I would like to invite Dr. Isa Calvin to share his perspective. So Dr. Isa Calvin is a renowned nephrology consultant and co-founder of the Arab Renal Care Group. So with over 20 years of in the field, his contributions span kidney transplantation, public health strategies, and also medical education. So he has also served as the president of the International Renal Care Association from 2018 to 2020. So right now I will share Dr. Ollie's presentation on his behalf. Let me.
And let me just, we can start the presentation, but let me just give you a head, Doctora, Professor. I just want to, we're a group of doctors. We do transplants. I mean, I usually do transplant. That's our main focus. And we have different centers in Bahrain, Saudi Arabia, of course, Jordan, and now we recently started in Libya. And we started in the probably in 2015, doing more complex cases, in cases donor or recipient. And we dived into the desensitized protocols, and we created our own protocols, of course, depending on the guidelines that we have. So we individualized the patient. But this case, it was a different case. This is a patient who presented to our group clinic in Jordan, and you can go with the first slide if you don't mind. Yeah. So he's 29 years old, and this patient had a history in the past of some kind of glomerular disease that he didn't have any, biopsy reports with him. He came from Saudi Arabia, and he came for a second opinion. So he had a kidney transplant in 2016. It seems it failed in 2020. And again, there was no biopsy proven other than a report saying this is probably related to chronic allograft dysfunction or nephropathy. So, he visited different centers in the region, and initially he came to a friend of mine who referred him to me, and because of cytotoxic cross-match being positive, his DSA is always high. He has multiple donors from his family members. He has a good number of cousins, and so initially we refused the case. We said this is going to be tough, difficult, and at the end we decided to pursue it. To pursue as the regular protocol, which is, for somebody who has a positive DSA, somebody who has cytotoxic cross-match positive, second kidney transplant, we said we'll go with the IVIG, plasmapheresis, and rituximab, and look at the DSA. Anyway, so pre-evaluation, we did lab tests, and of course, his DSA, as you can see, was high. Now, why we did, on what basis we chose our donor? Because there was multiple donors. Now, all of them had cytotoxic cross-match positive. All of them had the flow cytometry being positive, DSA being positive, but we chose the lowest DSA from his related cousins. And we assumed that the best match, or the best match with the best DSA will presume the donor. So we did that, and we did the first protocol. You can show if you want the second slide. So we did the protocol. We did give the patient rituximab. I usually give rituximab, and then I wait 2 weeks and start plasmapheresis, and with it IVIG. The bad thing is the patient had a reaction to IVIG. So the first dose of IVIG, the patient developed kind of a reaction, urticaria, rash. So we could not give IVIG, and we based ourselves only on, of course, the rituximab that we gave and plasmapheresis. And we did 5 sessions of plasmapheresis. We repeated the DSA. There wasn't much of decrease. And because I think of the rebound that usually happens with plasmapheresis, especially with not using IVIG, so that was a dilemma for us. So the decision was, let's repeat giving him another rituximab. But then the immunoadsorbent, idea came back, and we said, okay, let's use, immunoadsorbent. So this is where I contacted Nabil, and I said, let's try, modify our protocol since we're not using IVIG. So what we did is we give another dose of rituximab. Waited another 10 days. I usually wait whenever I give rituximab. So I usually wait 10 days, or sometimes 14 days. And then we did immunoadsorbent plasmapheresis. And then amazingly, the DSA went down. And then prior to the transplant, we did another plasmapheresis and donor-specific, immunoadsorbent. And we proceeded with the transplant. Now you can show levels that, yeah. So we proceeded with the transplant. In our protocol, we usually high risk, we give ATG. We give ATG 1.5 milligram per kg for 5 days. And of course, with methylprednisone. And then we go the same thing. We go with Prograf, tacrolimus, Myfortic or Cellcept, and then the prednisone dose. Of course, we give antiviral, antibacterial, and antifungal medication. Usually antifungal, I give it for 1 month, but the rest I keep them for 6, sometimes even higher than that. And we followed that patient because the patient is in Saudi Arabia. So we followed that patient the first 6 to 8 weeks. We removed the double J, and usually follow with DSA, and you can show the levels of the DSA. A few second slide. If you want to move to the, yeah. So we talked about that. If you can move to the second slide. Yeah. Yeah, this is the immediate post-operative. We didn't have any complication, but what I'm saying is we did follow the DSA. The DSA was low because sometimes when the DSA goes up, we do another plasmapheresis, and which this patient did not require. And we followed the patient, as I said, after 4 weeks, the serum creatinine was continued to be less than 1. And he traveled to Saudi Arabia. I just called him in the morning just before, giving this presentation. And it seems that he is stable, and he has at this point, has no issues. So, this is one way of adjusting the protocol because of something that happens, which, IVIG, I had 2 bad experience with it. So you have to modify your protocol before you presume with the kidney transplant. I don't know if you have any questions.
Dan, you did.
Hello?
Thank you for your presentation. Can I ask a question?
Yes, go ahead.
You did, as much as I understand, 3 immunoadsorption sessions.
Yes, we did 2, and then we did 1 just prior to. Even though the DSA was acceptable below 2,000, IMF was, and cytotoxic cross-match was negative, I still presumed before the transplant, before one day before the day of transplant, I did plasmapheresis, and immediately I did the immunoadsorbent. And the good thing was we do usually we do desensitization for kidney transplants. The thing is, I didn't have the rebound. I'm always getting worried from the rebound. And to be honest with you, plasmapheresis, because sometimes after the transplant, when you do plasmapheresis, the risk of either thrombosis or bleeding becomes an issue. And this patient, alhamdulillah, I didn't have any issue with that. So I'm not saying this is probably, this is one way of modifying your protocol based on what you see, your individual's reaction to your treatment. So, usually we do with IVIG, but this time we could not because of the reaction. So I had to modify it. I had to use immunoadsorbent. It seems it's working. I've used it before, but now I'm going to be, keeping it in mind for all my patients who has highly sensitized. So I'll keep that in mind because the rebound that I didn't get is something that I'm happy with.
Then immunoabsorption together with dialysis or immunoabsorption only?
Only immunoadsorption.
Oh, no.
I mean,
Yeah.
prior, I did immunoadsorption. Plasmapheresis, then immunoadsorption. Yeah, and Nabil was there. Yeah, yeah, it was different. So I'll put it this way. It was a little bit different.
Okay. Then will you follow or are you planning to follow up the DSA level of this patient?
Yes, we did. We did follow the DSA level of this patient. And the good thing is it was low. Now we followed it for after 4 weeks. I usually follow that. But then he traveled to Saudi Arabia, so I didn't get the chance to. But as I said, I called him today. It seems as his serum creatinine is stable and he's doing fine.
Okay. Then I just wonder if DSA level getting higher of this patient, for example, 1 year later. Just thinking, do you plan to do immunoabsorption again to this patient? Without rejection. There is no rejection, only the DSA level is getting higher.
I will. I will,
okay.
Victoria. I will. I will do that. And I usually do. I mean, we had patients who had DSA start going up, so I usually do. I mean, I don't wait until it goes up because this is probably early sign of possible rejection. So yes, in our because we sit and we discuss cases, but yeah, that's one thing that we need to probably let you know that we do that.
Yeah. Okay.
Hello.
Nice. Thank you very much. Nice.
Thank you.
So, okay, thank you, doctors and professors, for sharing your valuable clinical experience. So, we do have a few questions from our sales and marketing team that we would like to discuss with you. So, for Professor Dr. Ramos, so I would like to ask you that. So in your clinical practice, what is the key decision-making point for initiating hemoadsorption in your case? So what triggers you to start the hemoadsorption?
And then I did plasmapheresis a lot of times, and there is no answer. So immunoabsorption we usually don't use, but I was just thinking of to use it. For example, Dr. Isat's case also is a good choice. Together with dialysis, to do immunoabsorption, maybe because she's second kidney transplantation, most probably she has got combined type rejection. If I can do biopsy, we will see this. Those immunoglobulins that are causing rejection can be effectively taken out by immunoabsorption. So just to do this, I just thought at the same time, as I said, Jafron was here. Just a perfect combination. And I also did immunoabsorption to another patient with second kidney transplantation. He had kidney transplantation in Istanbul, but he has got very high PRA levels before transplantation, highly sensitized patient, but he didn't get any kind of desensitization protocol. Only thymoglobulin and plasmapheresis was done to him, and he doesn't know any other he did take or not. So his creatinine level get a little bit increased. His usual creatinine level 1.5, 1.7, but his creatinine level get increased to 0.7. Then I did to him also with biopsy, and we saw in this patient combined type rejection, and I did to him also ATG together with immunoabsorption, and his last creatine level got now 1 week ago. Just I wanted from him to do again his creatine check 1.7. He's good in condition. Maybe just thinking it can be like Dr. Issa protocol. It can be put in to do immunoabsorption is a perfect way without plasmapheresis can be done. Just immunoabsorption can be done for those patients. It can be useful.
Okay. Thank you so much, Dr. Pava. So for Dr. Issa, I have a question that so looking at the future, so what in your opinion is the most critical next step in research needed to solidify the role of hemoadsorption in transplant medicine, especially in field of kidney transplantation? So what's the next step? Like, what's the most important next step?
Thank you for this question. Yeah, to be honest with you, is because we're expanding our transplants, we're including more patients, and because we're seeing more patients on dialysis or patient with end-stage renal disease. So the question is how can we do that? And I think adding immunoadsorbents, especially in the recent protocol, will help minimize the risk of antibody-mediated rejection, and that will help us to expand our practice. The other thing is, of course, immunoadsorbent is, I mean, you talk about kidney transplant, but I think it will minimize the risks of using, immunotherapy. And I think down the line, there will be new protocols to minimize the use of our immunosuppressant that we use. And that will help minimize the risk of infection and possibly the malignancy and cancer. Let me just rephrase this again. I looked at many studies, and and I don't know if Kamal, the professor, will agree with me, that acute rejection, I'm talking about transplant, acute rejection, okay? Doesn't matter if it's human rejection, antibody-mediated, or non-antibody-mediated rejection, is the only factor that will affect the long-term effect of the graft survival and overall mortality and morbidity, even malignancy and infection. So if you do that, if you can adjust the protocols to minimize it, at the same time, minimize the immunosuppressive medication or adjust them in a way that we have a better protocols, I think that will expand our number of patients that can do transplant. You can do a second kidney transplant easier, much easier, with less sophistication, with less complication. And at the same time, even our own patient with still that high-risk patient that we consider intermediate high-risk patient can benefit from that immunoadsorbents in the future. That's what I think we should do.
Okay, so thank you, Dr. Issa, for your opinion. To summarize what you just said is basically that one of the most significant advantage of using hemoadsorption in kidney transplant is that there is a possible ability to avoid IVIG substitution. So maybe that in the future, maybe more and more doctors and institutions can establish a more comprehensive protocols for patients to minimize the risk of rejection and to increase the rate of transplantation more successful. So I would say that. And so to summarize this academic exchange, I would like to thank you, Dr. Yaus and Dr. Khalid, for sharing your valuable clinical experience. So
Thank you.
So we truly appreciated the depth of the insight shared today and look forward to our future collaboration. So now I would like to propose we all turn on our camera to capture these memorable moments together.
How to do that?
So we just turn on our camera. So someone will, yeah. All right. So I would like to thank you both for participating in this insightful academic exchange, and I hopefully in the future many doctors and patients will benefit from using hemoadsorption in kidney transplant field. So and I would like to thank you everyone that behind the scene to make this exchange possible. So thank you for your time, and I would like to see you next time.
Okay, thank you.
Thank
Thank
you.
you.
Thank you so much. Thank you so
Thank
much.
you
And
so
I
much.
actually,
Thank you,
Yeah,
Doctor.
thank you so
I want
much,
to,
Professor.
but
Bye.
I want to extend my invitation to Doctora to come and visit Jordan. I don't know if you've had, and we've been to Turkey, and I went to the medical park many times. So, but so you have to come and visit Jordan. It's an open invitation. I don't know if they asked you to do so, and you are more than welcome to come. We will have, we will ask, our colleagues to give you as I said, a special invitation because I want you to come to Jordan.
Okay, I hope one day in future I want to come and see your institution also. Thank you very much. You're welcome here also.
Thank you, Yalla. Goodbye. Thank you so much.
Okay,
Thank you.
bye.
Bye. Bye. See you next time.
Bye.
OK 了哈，谢谢你啊，Thank you，Moni，See you 啊，没有你走了，OK，就这样。